that is, what is the pharmacotherapy of depression? We have seen classification of these various tests which are there, or various questionnaires for depression. We have seen various grading ways how the depression is graded: mild, moderate, severe, etc., using various scales or various questionnaires. So there were several scales are there, like DSM-4 was there, Hamilton was there, and many more. So all these questionnaires, they give one information that what is the severity or what kind of depression the person is having, and accordingly we have seen that various treatments were suggested. We have seen the first line treatment. We shall go for, then we have discussed one thing is we have to go for augmentation whenever we feel that one drug is not appropriate. So we are discussing about the next strategy about augmentation, how we are augmenting. So so far what we have seen, we will go through this and we will see about augmentation. So how we are assessing this depression, because we have discussed this, that we don't have any direct measure by which we can have. Just like in hypertension or cardiovascular system, we have got hypertension, you can measure blood pressure. In cardiovascular problems, if there is a problem, then there are several measures like 2D echo, or maybe you can go for angiography or ejection fraction, and many more visible diagnostic tools are there. Here we don't have visible diagnostic tools apart from the symptoms, and for that we go for various scales or various questionnaires, and from that we get assessment about suicidality, bipolarity, comorbidity, whether any other psychotic disorder is there, and what concomitant medications are going on, and what are the special feature about that disease in that particular person. Then we may go for laboratory assessment, particularly if we have seen that cortisol levels were changing, so we can go for that cortisol levels and other such things. Then there is approach that don't go for any medication because medications may affect, and go for patient education, go for guide about patient about compliances, self management techniques, psychotherapy. These are non-pharmacological therapies, and they can help to the patient without, or particularly these are helpful only in the milder cases. Because if the cases go ahead, if it becomes moderate or severe, then this may not help. Then acutely monitor every 1 to 4 weeks. The period of the greatest risk, depending on the severity and response, that has to be checked, and follow up every 2 weeks for longer. This is initial one. Initially one has to go for this rigorous checking, so that one can understand what kind of situation the person is having, and accordingly one can go. Then various use of validated scales are there. We have seen this is Hamilton D scale is there, Hamilton scale for depression. Like that, what's your scale which is validated or which is found good by that clinician, that clinician can use it, and accordingly the clinical psychiatric expert will deliver the scale and accordingly get the result. And accordingly, once that scale is used, then go for continuous this monitoring, as we have seen earlier, 1 to 4 week or 2 to 4 weeks, depending on the severity of response. Then accordingly we'll go for that. After monitoring, we'll understand the situation, the status, and then accordingly antidepressant selection can be there. It can be individualized depending on the symptoms, the profile of the person, what are the comorbid conditions, what are the tolerability of that particular drug. If already the person was on treatment, then what are the previous responses. If any other simultaneously or concomitant drug is being administered, whether any drug interactions are there, and what is suiting the patient the best, and then definitely cost, as we study it in pharmacoeconomics. So how they are done, various these randomized clinical trials, RCTs are there. On that basis, what's your knowledge is there. If this is what part is what we call is a evidence based, we have got topic here. So evidence based means what happens is what's your evidences are there in that is what's your clinical trials are conducted on that particular area or on that particular disease, and at various places various drugs are used. So at various places when various drugs are used on that particularly this data is collected. Particularly it is collected from either raw data or from the published articles. Suppose there are how many clinical trials are conducted in various patients, then in that patients whatsoever data were there, particularly in good articles, everything will be there. There will be very nice separation of mild, moderate and severe cases in that particular hospital. How many mild were treated with drug A, how many moderate were treated with drug A, how many severe were treated with drug A. Similarly, drug B, drug C, drug D, and accordingly what were the impact in with drug A, drug B, drug C or drug T in therapeutic outcome, that is whether what is the prognosis out of it, and second thing is what are the adverse effect. So this whole data is combined together, that is collected together, and this data is then used for preparing guidelines or making this overall view is given to the society, that means to the clinicians who are working in that particular area, and this will help the other people to judge what is the best medication. If normally in best medication what we do is we make the analysis, benefit to risk analysis. If benefits are more, risk is less, then for that that particular drug is good, that particular moiety is good, and accordingly we can go for that. In certain cases the drugs are not offering that particular good benefit, but they are unique in particular cases. In that cases we have to use unique. So like that it is there, and then on that basis we get the drugs, then we make the line of treatment criteria, first line treatment or level 1 treatment, level 2 treatment accordingly, where we know we go for more safety and comparatively, as I told you, more safety, inclination and better therapeutic effect. So on that basis we go. Second line are comparatively having more toxicity comparatively, so we go for second line, and then the third one is they are having whatsoever higher activities and safety and whatsoever clinical effects are there. So accordingly we decide first line treatment, second line treatment, third line treatment. So various evidences are there at various places. Now level 1, level 2, level 3 and level 4 evidences, you can see that what are these. Level 1 are clearly obtained from various clinical studies, that these are there, these are obtained, these are proven. If you look into various chapters in DPRO or other such book, you will find these various levels of evidences. This shows that it is very clearly indicated in many clinical trials, that is more than clinical trials, and these levels will show example already it has been given above. So level 1 shows that at least 2 clinical trials, randomized clinical trials, and it has got adequate sample size preferably, and these are preferably placebo control, and there is a meta-analysis with narrow confidence interval. That means narrow confidence interval means if you refer, yes, I can see that you have referred many articles during your this other subject, I think biostat and research methodology. So what is a confidence interval? I am very sure you might have gone through, but I'll just make it in short. That confidence interval gives, suppose it is made 0.05, that means 0.05 data means other 95% is data which is it is reproducible. Okay, that means at any time in any given circumstances, that 95% of the data is reproducible, and there is only 5% chance the data is not reproducible. So as you reduce the confidence interval, that means you are making more chances of the repeatability of the data, and in that cases if the data is repeatable, that means it becomes more and more trustworthy. So level 1 are the evidences. These are giving you evidence based, again we will discuss it in brief, but I hope this will help you. whenever these levels are there. So when at least two randomized clinical trials they are conducted, they are having adequate sample size. This adequate again are decided by statisticians. So they will decide it for given type of study how much should be sample size, and this sample size should be as far as possible placebo controlled, and there should be meta-analysis with narrow impedance, narrow confidence interval. So this is level 1. In level 2, only one RCT is required, at least one RCT is required, and the confidence interval are not narrow, they are wide one. Instead of 0.05, it can be point or 0.1 or 0.5 like that. So here we are increasing number of this confidence interval, or that way we are decreasing the reproducibility of the data. Third one are the non-randomized controlled prospective studies. They are not randomized. So when the studies are not randomized, they can be biased one. So these biased studies are there. Therefore, we are putting it to level 3. That is, we are not having much trust over that. And lastly, fourth one is expert opinion or consensus. That suppose various clinicians say, we have not studied it, but this is what we feel. Okay, and there are 10, 15 scientists or researchers in that area. They are saying that this is our opinion, but it is not officially brought into books or articles or as a research. So this is level 4. So any first line treatment, usually we'll call it as a either level 1 or level 2 evidence it is having. That means it has been observed and verified and proven in level 1 and level 2 evidences. That is minimum 2 randomized clinical trials are there, plus safety is there, and clinical judgment is clear about it. People have put all their notes and their objections or their reviews on that particular, when we call it as a peer reviewed one, earlier one. So there we get all this inputs, and on that inputs whatsoever final version is there, then it is going for clinical judgment. So these are level 1 or level 2, we go for first line treatment. Second line are usually level 3 evidence is there or higher. That is, it can be level 1 or level 2 also, but it should be minimum level 3. And third line are having level 4 evidences or higher, and they must having simultaneously safety data and clinical results which are shown or which are observed by people, and they are put somewhere, they have mentioned. So these are how we decided the level of evidences and line of treatment. So accordingly, we'll go for what we are having. This is for depressant. What we will do is there are 3 major systematic reports are there, and they may not find unequivocal efficacy or tolerability differences among the second generation antidepressants. So there are various reports are there, and one report is saying one kind of drug is more effective or more tolerable, other will say that. So we'll say that unequivocal. Okay, that is, they are not having same voice, they are not having same opinion. So in that cases, what we are doing? So all that must have level 1 evidence to support evidences. There are no consistent predictor of outcome. So if it is not known that what can be the prediction or what is the prognosis, as we have discussed earlier, while most second generation antidepressants are first line one. Second generation means, if you remember, we have classified them earlier in pharmacology, that is first line were the older one like MAO inhibitor and tricyclic antidepressant, while the second generation are new SSRIs and SNRIs. So these are, most of these are second generation one. So let us see the list of these. We'll go again generation wise. Here what are the first generation, first line recommendation? These are the first line, means they are having evidences, more evidences. We know now what are the evidences. So here the evidences are, they are more comparatively. Just a minute. So these are what first line recommendations are. First is means there are many actually: bupropion, citalopram, or S-citalopram, then desvenlafaxine, that is des analog of venlafaxine, duloxetine. We already classified them earlier. Now there is a difference. We have classified them on the basis of pharmacological basis, acting as a on what, like tricyclic antidepressant, then SSRIs, then SNRIs, then having some other actions, then tetracyclic one, like that. Okay. Now here we are classifying on the basis of their actual outcome or actual therapeutic use. So first line recommendation are bupropion, citalopram, desvenlafaxine, duloxetine, S-citalopram, fluoxetine, fluoxamine, then levomilnacipran, then metrazapine, then paroxetine, sertrazine, venlafaxine, then vilazodone, then vortixetine. These are various compounds. The list is updated when it is having latest compounds which are not there or which were not there in DPRO when we were seeing it. So this is having all this first line treatment. These are the first line recommendation. Second line are amitriptyline. These all are the older one because they are having, although they were effective once upon a time, they were known as a very effective. We have seen their problems. Example, tricyclic antidepressants, they are taking long time. They are having many adverse effects, and because of that, later they are now taking as a backseat. These were the first generation one, and the newer one which are there, they are now becoming the first line treatment. See the thing is, those which were first generation, they become second line. Those were second generation, they become first line treatment now. Then quetiapine, then many atypical antipsychotic agents. Antipsychotic agent as such we shall be seeing later also, but it has been proven that many antipsychotic drugs, they are being very effective. We have seen that in many times. It can be a bipolar depression. Even in unipolar depression, it has been found that some of the antipsychotic agents, they are proven very effective. And this is again one more what we can say contrast to, I told you to read, those who have read it, that was called as a monoamine theory or biogenic amine theory. And it was saying that theory was saying that all these drugs, actually depression is because of the depletion of amines, and the mania is there, or the what we can say excitatory phase of diseases are there. They are because of the increase in the amines, and therefore we are working towards decreasing the level of amines or decreasing the amine action in the people who are having maniac one, and we are trying to increase the efficacy or increase the activity of the drugs in case of depression. So this was the basic concept earlier. Then people are having these questions nowadays, then why these antipsychotic drugs which are supposed to be opposite to antidepressant drug are being effective? And then it is then coming, or it is now leading to information that it is not that simple one. There are lot of changes are taking place, and they are taking place maybe far away from one place to other place. Means drug is acting at some place, on that basis some neurons are changing, on that basis it is causing changes in the other neuron at other area, and this may be reason behind why this is taking long time. This is taking few weeks in showing action, and why the drugs which are supposed to having opposite effect are becoming effective. So these are various reasons why these are there. So these are the second line recommendation are quetiapine, then some other atypical antipsychotics, then selegiline, then trazodone. This selegiline is irreversible MAO inhibitor. Already we have seen MAO inhibitors during that, but MAO inhibitors are having many adverse effects. And third line are phenylazine and trinylcypromine. These are also MAO inhibitors. So these are various MAO inhibitors. Now we are putting MAO inhibitor as at a later stage or in a later condition. Maybe when we feel that first line drugs are not working nicely, they are having some problem. Fortunately, we have got so many first line drugs. Now again question comes, and that has been answered above, that out of this so many first line treatment, which should be used first. So again it will be patient specific, and clinician will decide on the basis of the simultaneously drugs which are being administered, whatsoever drugs are there, accordingly wherever drug interactions are there, on that basis this to avoid the drug interaction, the other drug will be used. So there are many things the clinician will have to keep in mind, and on that basis the drugs can be prescribed, whatsoever the best is there. Now next is, what is augmentation? We have seen that is augmentation, that when from the beginning we give two medication, we call it as a combination. But when we start with one therapy and after some time we add another one, then we'll call it as a augmentation. This already we have discussed in our earlier class. So usually when monotherapy is the largest naturalistic outcome study, because whenever monotherapy is there, it has been found that most of the patient are giving good prognosis. 80% of the patient had chronic or recurrent depression, and most have comorbid psychiatric or medical conditions. And when the studies were done, it shows that remission rate for this Hamilton D scale were 28%. The other one, that is Quid's SR scale, was around 33%. And there was quick inventory of depression in these various people. So there is one more study was there, that was known as STAR D data. So this STAR D data was a big study which was conducted, and it was an open label study for citalopram for 12 weeks, and 56% of the patient, they achieved response after 8 or more weeks. Then 40% of the patient who ultimately remitted first achieved remission after 8 or more weeks, and the patients show minimal improvement, that is these were greater than 20% improvement in rating scale after 4 to 6 weeks. Should be continuing on the antidepressant for another 2 to 4 weeks before considering additional strategies. So these were the strategies for finalizing augmentation. So how long we are going to go for monotherapy, how long we should wait, that when we are not getting desired clinical response with the monotherapy, then when we should go for augmentation. So this was one of the study which indicated that yes, when alone almost 12 weeks was there, and 40% of patient remitted in first, they remitted after 8 or more weeks. That means if it is there, that means they do not need it. But those which are having minimal improvement, they after 4 to 6 weeks, they should be continue on antidepressant for still more 2 to 4 weeks. So how much it becomes? Almost 8 to 10 weeks maximum. After 10 weeks, then you can go for planning about other strategies, what strategies you can make about whether you should go for augmentation or not. So in what condition monotherapy become inadequate? The target goal for acute treatment should be remission. So our basic aim is remission, means we should get reduction in these scales where they were showing the depression, at least from the moderate to mild it should become. So that shows that sign that yes, now the treatment is working. So the acute treatment should be remission. Remission can be both, that is total zero, that is no no disease or no signs or symptoms of the disease are there, or there can be reduction into it. The resolution of depressive symptom is there. The response to treatment, that is reduction in the symptom level, is not an adequate outcome in that. So it should be total remission, it should be zero, then we'll call it as a adequate treatment, otherwise we'll not call it as a adequate treatment. The residual depressive symptoms are the risk factor for relapse, and then it becomes negative predicted for the long term outcomes. Then when we should go for augmentation? After 6 to 10 weeks of the treatment with monotherapy at a maximum dose which is well tolerated. Now maximum dose may be reported in books, but you have to check with the patient whether it is tolerated by the patient is or not also. Switching is deemed like to be is less effective if it has been already attempted. Now switching is what? You started with one drug, you waited for few weeks, and then all of a sudden you think that no, it is not working, I will go for the next. So it is not done immediately. It becomes less effective if it has already been attempted. Further, monotherapy trials are unjustifiable because of the acuity, means we cannot go one after another. So once monotherapy is not responding, then go for augmentation. The trials which are failed to achieve remission, in that you can go for augmentation. You can continue the current agent which possesses partial efficacy and is well tolerated. You continue it and then add another agent into it. Re-evaluation does not change diagnosis in that cases, or you feel that when you are evaluating it again there is bipolarity, depressive subtype or comorbidity is still there, then you have to go for augmentation. Now question is asked whether you should go for a drug with a different mechanism. It is not, it is not mandatory. You can use any type of drug. So no conclusion evidence are there for switching out class. Switching out class means what? We have got various classes. If you remember pharmacology well, we have got example tricyclic antidepressant, we have got SNRIs, we have got SSRIs. These are various classes. Or agent like bupropion, which are typically different agents. Then we have seen that there are antipsychotic drugs. So there are variety of drugs are available. These are various classes, and we started with one class. Now the question again come into mind, then if one class is not working, then what we should do? Should we change the class? Earlier SSRI was there, example fluoxetine was there given. Now should I go for diloxetine, which is SNRI? These are the questions. Now it is not such evidences are not there that switching over class or switching over within the class. It has not been conclusive evidence are there, means the data is not clear about it. Small differences in outcome may be a result of enhanced efficacy of some antidepressant regardless of mechanism of action. Maybe means whatsoever mechanism they may be having or whatsoever class they may be having, but in some cases this may show other drug may be showing more efficacy. So whatsoever mechanism it may be having, even though mechanism has changed, maybe just like fluoxetine and paroxetine, both are in one class. So suppose fluoxetine is not working and paroxetine is working, that means that in the same class the other drug is having more effect. Okay, it has got more efficacy than the previous one. So in this trial, in STAR-D trial, switching within the class was just as effective as switching outside the class. Within the class you understood now, within the class was what? From the fluoxetine to paroxetine, that is the same class, SSRI. And switching outside the class means what? From fluoxetine going for diloxetine. So here it says that the that particular study, STAR-D study, switching within a class was also effective. That is from fluoxetine to paroxetine if somebody is going, or maybe I am discussing only first line here, but suppose it is a second line drug also. So it was tricyclic antidepressant earlier, amitriptyline, and if you are going for imipramine, then switching within class. So still it was effective. Augmentation and combined therapy are not the same. The augmentation and combination therapy, I told you, augmentation is adding a second treatment in ongoing antidepressant treatment. Combined therapy is combining two treatments from the onset of treatment. So we'll go for augmentation. What are various drugs which are there? So these are aripiprazole. These are the drugs which are given for mood and anxiety. Like aripiprazole, lithium, olanzapine, all these drugs we shall study in antipsychotic later, but as I told you, they can also be used. There are some second line treatment like bupropion, metrazapine, quetiapine, triiodothyronine. Now this is again unique. You will find that triiodothyronine is what? It is a T3, that is, it is a thyroid hormone. It has been found that it is also working in many people, and it can be given as a level 2 drug. Then other antidepressants can be added as a level 3 drug. In some cases, fish oil, that is because of the omega 3 which are antioxidant. It is believed that oxidative stress is causing problem in people, and because of that these agents, omega 3 fatty acids or fish oil which is rich in this omega 3 fatty acids, it is given. Then psychotherapy and cognitive behavioral and other therapy, that is the psychotherapies are there. So these are various psychotherapies and cognitive behavioral therapies, they will be helping the people. Then third line can be buspirone, then modafinil, then various stimulants like caffeine or maybe other stimulants can be given. Then ziprasidone is the drug which can be given, and there are unranked agents like some of the anti-epileptic medicine and pindolol can be given in some of the patients. So this was the studies from the Canadian network for the mood and anxiety treatments, and these were the ranking of the strategies. Now let me tell you one important thing is, at many places you will find that anxiety and depression are having almost hand in hand, and therefore whenever such mood, particularly depression of mood is depression and anxiety is there, these agents are believed, these agents are taken into it. Now these all drugs are there. I will not take drugs now like lithium etc., because all these drugs we are going to study later as antipsychotic drugs, or the drugs used in bipolar diseases, or drugs used in the various anxiety diseases. This we shall study later, and then we'll add up into it that what are the better one. We can sum up in addition to antidepressant. We'll see that what other strategies are being utilized by people and how it is being done. So I hope you are understanding this. Please go through pharmacology. In the meanwhile, we shall go for all other drugs which are there, because I'll not go for now various pharmacology of these agents. Already we are having about it, and whatsoever pros and cons are there, these are the addition of these drugs. We shall continue after our vacation. Whenever we get time, we'll discuss it. So by the time, let me wish you all a very happy Diwali, and